Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Abdullah Hachem from Barcelona, Spain. Dr. Hachem is Associate Professor of Orthopedic Surgery at the University of Barcelona in Spain. He's head of the Shoulder Surgery Unit, associated to the Universitario Baleares and Tecnon Medical Center. He's also Director of the Master Fellowship Program at the University of Barcelona. Dr. Hachem is member of the Executive Committee of the Spanish Society of Shoulder and Elbow and is a past member of the Executive Committee of the Spanish Arthroscopy Society. He also chairs the Barcelona International Arthro Shoulder courses. Having exclusively practiced shoulder surgery for the last 10 years, he focused his research activities in the cutting-edge treatment of glenoid bone loss with free metal fixation systems. He is president of the upcoming Spanish Arthroscopy Association Congress in 2024. Dr. Hachem is highly cited researcher and has multiple publications in very high impact journals, especially in the field of shoulder surgery, and is also a reviewer for the Journal of Shoulder and Elbow Surgery and also the American Journal of Sports Medicine. So today is my great honor to introduce you to Dr. Abdullah Hachem from Barcelona, Spain. Over to you, Dr. Hachem.
Thank you very much. Good afternoon, everybody from Barcelona, Spain. And thank you, Dr. Hide. Thank you, Luai, for having me. It's a huge and great honor for me and pleasure to be here in this wonderful website with orthopedics principles around the world. So my talk today is to explain why and when and how, for me, iliac crest bone graft, metal-free cerclage system is my preference to Latarjet. So this is my disclosure. So there are several recurring risk factors for the bunker repair. From these post-op risk factor, I want to focus on glenoid bone loss, based mainly, as you know, off-track, critical, subcritical, bipolar, but I prefer to focus in the glenoid bone loss. So when we define the critical bone loss today, we should remember this publication from Itoi, Burkhardt, and Yamamoto in 2000. For Itoi, the threshold was 1%, and for Burkhardt, as you know, with the inverted pier, was 25%. Yamamoto in the same year described at 19%. So as you can see, there is no controversy regarding bone loss at more than 20%. So 15 years after, for the first time, as you know, Shaha in state published and described AGSM in 2015, the threshold and the new concept is subcritical bone loss. And he put the threshold at 13.5, based on the lower and unacceptable WOSI score ranges, not in recurrence rate. 2 years after, from South Korea, this works comes also to put another threshold to the bone loss for regarding to instability and failure repair at 17.3%. But the criteria was recurrence for recurrence was defined as revenge surgery or subjective instability or apprehension. And recently, this paper comes from Shoulder and Elbow. This author, Cavalier and Pascal Boileau, they put the subcritical bone loss at 10%, associated with an age less than 23%, that is a high risk for failure and the operation after bunker and remplissage. So, in conclusion to this introduction, there are no linear relationship between the size of the glenoid defect and the stability. And the critical value for glenoid bone loss is different for every patient, as the glenoid tract is different for every patient. So, in conclusion, we came from critical with 20% of the defect to subcritical with 15% of the defect, and now maybe we can say now we are with non-subcritical with a 10% of the defect. So maybe the concepts are changing with the time. And in my own opinion, my experience also, the treatment algorithm for recurrent instability with glenoid bone loss has changed frequently. Recently also, this is paper for Isakos in 2021 is a consensus between surgeons to define the bone augmentation and the state of the art for this pathology. And they put again the range between 13.5 and 20% of the glenoid bone loss as subcritical bone loss. So for me and for in the majority, without controversy, all you need is bone, as the Beatles song. So at least for me, on the glenoid side. So let's go to see what's happened and what we have. All of us, we know bone block can be done in an anatomic way using an iliac crest, bone graft, allo or auto, or in a non-anatomic way using a coracoid graft. All of this, we know this is a lateral procedure. So, as you know, but for me, the big question, and has a challenging answer for me is, in which cases would the sling effect be needed? So to answer this question, let's go to take a look at the literature. Complications of lethargy, this amazing recent systematic review, more than 4,000 lethargy, 72 studies. Complication rate, if you take a look at this, is 16%. So 16%, but the standard deviation, look at this, from 2% to 78%. And the revision rate was high, not high, lower, 5%. Again, the revision rate is variable between 0 to 26%. What does it mean? That means for surgeons who do a lot of surgery of lethargy, it may be the frequency of complication and revision is lower. But for majority of surgeons who did not do a frequently lethargy procedure, this maybe can be produce a high complications and revision rate. If we take a look again at a complication related to the screws intra or post-op, it is frequent, between 6 to 10%, due multiple complication as position, direction, fractures, malunion, and this is in the immediate post-op and intra-op. But again, for the post-op, all of us know the osteolysis can be done as screw protrusion, metal irritation, pain, and humeral calcareous damage. So if we compare, or when we want to compare lethargy against bone graft, this is paper from Europe, from my friend Philippe Roda, with a good criteria level 1 comparison between all the patients with a glenoid bone loss more than 15%, and they compare 29 cases against 25, and look at this. No differences was found in related to row score, subjective disorder value, ASS score. The unique difference was for internal rotation. I mean 70, 79, 79, 80. So regarding to post-op traumatic dislocation apprehension test, there are no difference. They reported the donor side disturbances, 26%, and the scapula is interesting to find here, 13% of dyskinesia in comparison to 3% with J-graft, bone graft. This is, as you know, they put the graft without any type of fixation. So the complication rate was the same. Now we have a new meta-analysis to compare the bone block to lethargy with more than 4,000 cases. Again, no failure differences, no complication differences, and without statistical differences. The return to spore a little bit higher with bone block, for bone block, and arthritis a little bit much more with lethargy. And here, ACES score was definitely, and the unique differences and statistical differences to the bone block, 3 times much more than ACES. Maybe that because in state, the bone block and lethargy is not the same. Lethargy for all of us, we know that some throwing athletes can be returned to sport at the same level. And if we take a look again as a literature with this meta-analysis again from the last year, they used autograft, allograft, bistatic allograft, whatever they fix the methadone fixation method, screw, metal, bioscrew. All of this presented a recurrence rate lower, 6%, a radiological union high at 92%, and all of this improves WOSI score, ROE, subjective disorder value, constant score with good MCID and low rate of complications again. And if we take a look again, is in the concept, the non-lethargic procedures, and we could compare between autograft and allograft also. If with a good follow-up, no failure, no complication, 3%, 5%, return to sport higher, and arthritis maybe a little bit higher with autograft, because with allograft instead, sometimes they can use a fresh distal tibial allograft in contact with the cartilage of the humeral side. So in conclusion for this introduction, my preference after I started in 2011 and with my experience is to do a glenoid for every glenoid bone loss more than 15%, to use iliac crest bone graft. We started in 2011 to use this one, but fix it in by biocompression screws to fix this bone graft. This is the same work and then published by Markus Scheibel. So in order to improve and facilitate this technique, we started to use buttons to fix this bone graft, as you can see in this videos and these slides. So after having done 21 cases, we found a complete bone integration. Despite osteolysis, we didn't find any clinical failures. So in December 2018, we started to use for the first time a bone block cerclage. In this case, in the first case we used one cerclage suture with a posterior button, a dog bone button. So as you can see in this video done by my friend, product manager, Alex Campagnoli in Munich, and using one cerclage, we found high rotational stability. I mean, this is not good for stability in cases when you use a big bone. So we started to use 2 tapes cerclage with different colors in the same tunnel. As you can see, again, look at the comparison here, much more stability with rotational and displacement. So we published this technique in 2019 using 2 cerclage tapes sutures in the same 2.4 millimeters tunnel, and then interconnecting the sutures. I'm gonna go to give you some tips to this technique. Through the rotator intervals, we introduce the graft pulling from posterior side, pulling the tape individually and alternatively, as you can see in the right video here, to help the graft to introduce through the rotator interval. Use here a sealing, if you can see here, the sealing here, and some finger of my assistant help us to introduce the graft. So when the graft is introduced, we should interconnect the sutures, because it's very important to allow a consistent reduction and symmetrical tensioning of the nuts down. And at the end, we should do an alternating symmetrical traction on each cerclage suture limb separately to reduce the nuts and avoid slacks. At the end, only by hand, we reach a strong fixation after manual tensioning alone. And we should use a tensioner and to tense to 25 or 30 pounds. Now we have a protocol after having done a lot of cases. This is what is advised, 25, 30 pounds. At the end, I prefer to reattach the capsulabrum complex to the glenoid rim, leaving our graft extra-articular. I prefer to use all fiber tap knotless because I use unthreaded key wire that could avoid any tape damage to the channel and the construct, the final construct. So to answer the question, in which cases would the sling effect be needed? For me, restoring the anatomy, doing a bone block, and the pancreas repair on the top, with the capsular shift application from distal to proximal, as you can see in this video, we detach all the capsule, we conserve the capsule, and until 6, 7 o'clock, and we bring it from distal to proximal and fix it on top. And the right side, you can see here at the end, the graft, and always we reattach the capsule with the fiber tack system knotless. So to answer this challenging question, for me, is not necessary, because with bone block glenoid reconstruction in patient with glenoid bone loss, we don't need, for me, the same effect. And also, look at this case. We revised a lateral J arthroscopically to remove this screw. It took for me the last month almost 35 minutes. But to revise this case, the first case we revised with bone block cerclage, because this patient has a full resorption of the graft. The graft was bad from the band tissue. Look at the tape here. The tape it took me 5 minutes to cut the tapes and to do a new tunnels 2.4, and doesn't matter. So this is the difference for revision case, is also we don't need to remove hardware. So we published our first 21 cases with a follow-up 12 months, and all of them we follow by pre-op CT scan, post-op immediate CT scan, and at 12 months. The rate of healing rate was 95%, and the osteolysis in the beginning at 1 year was, as you can see in these slides, in zone 4 and 6. We divide the graft in 6 zones: 1, 2, 3 close to the glenoid rim, and 4, 5, 6 far to the glenoid rim. And mainly the remodeling of the graft was mostly occurred on the edge and outside the bed fit circle. So the WOSI score, ROWI score was improved from the beginning, from pre-op to 6 months and 12 months, with a P statistical significance for these results. We follow this patient also at 24 months. This data is unpublished. We are preparing now our manuscript, and we analyzed zone by zone, every single zone. And now we found the graft resorption increased from the farthest zone 4-6 to 4-5-6. That means now the resorption again occurred in unloaded zone outside the best fit circle. And out of 21 patients, we divided the first 15 cases we did with allograft, and after 6 cases we did with autograft. So we had 3 cases with full resorption from the allograft, because 2 of these 3 cases was a really bad graft comes from our bank tissue, and only 2 cases presented a subluxation or dislocation, and from the autograft from this 6 patients, no one have any problem with this autograft. So we did analysis also now as you can see in this slide, from the pre-op, post-op, 6 months, 1 year and 2 years. So this is an area, glenoid surface, global glenoid surface. The patient pre-op was almost, because our defect was 15 until 20, the area pre-op was 85%. So always we put our graft bigger than the best fit circle. So the immediate area post-op was 120, 125. And 1 year after, this is the remodeling here. As you can see, the blue one is the autograft, and the orange one is the allograft. The behavior of the autograft is much better than the allograft, but still there is because of only 2 and 3. But this is one of these 3 patients has 15% it is still perfect without any recurrence rate. And this is the 2 cases here with the recurrent rate. So the behavior is different, but still the final area at 2 years, we're using allograft also is still there, and almost 95% of the glenoid area. And we compare regarding to OSI score, RO score, constant score, SSV, both, we didn't find any different significance between both. And the MCID only little bit much better with the autograph, because these 2 cases with allograft. And again, we compared the range of motion between the affected arm with the contralateral arm. At the end, we find statistical significance for external rotation with the arm at the side and the arm in abduction. But if you take a look at this difference, is 8 degrees for the first one and 10 degrees for the second one. But no patient suffer or complain about this, because all these patients, they have hyperlaxity, I mean 120, and they lost 10 degrees, and 90 degrees at the side, and they lost 10 degrees in some time. So let me show you some results with using an autograph. As you can see, this is amazing 1 year, well, no doubt about autograph. In this case, we restore, look at this, we restore the concavity. I sometimes use CT scan 2D or sometimes 3D. And this is what our big result with allograft. Look at this, 3 months after allograft. And this case, the first case, we used bone block cerclage. And for this first case, we couldn't do CT scan post-op because we didn't have the final approval from the ethical committee from our hospital. There's a second case, again, 12 months, and the allograft suffered a resorption, remodeling from the first year to the 2 years, still there. This patient with allograft also. And this is, look at this, this is always our graft, I explained, bigger than the best fit circle. This is what at the end, bigger in two dimension. I mean, from anterior to superior, and from superior to inferior, posterior anterior. That covered all the best fit circle area, and we don't worry about where we're going to put our graft in the middle. And at the end, we put it bigger, and the remodeling do the nature. At the end, this is a vision of 24 months. Another case, amazing what month post-op, and look at 2 years post-op in this case. So we did now 48 cases, 33 autograft, and now only 15 allograft. And in summary, we could say this is a safe profile technique for a follow-up more than 3 years. We didn't find any graft breakages, any vascular lesion, no stiff, some infection, one case, and some patient complained about smallest hypoesthesia in the zone familiar crest bone graft. And this is smallest glenoid tunnel we can be used, 2.4. I prefer 2.4, but you can use 3 millimeters. And using 4 tapes, that allows a press fit tunnels, and interconnecting these tapes, we can achieve a strong fixation, mimicking a compression plate. This is give us a high rotational stability. At the end, we don't need any auxiliary or supramammaries portal. And at the end, and this is, we publish this technique for anterior bone block, for posterior bone block, and also for lateral jet without any type of metal. This is a big advantage of this technique, a metal-free implant. Permit me to invite you to our next international Arthur Shoulder. This is a 6th edition. With, as you know, in this we will do 15 surgeries, live surgery, simultaneous surgery. So I invite you, all of us, and thank you very much again for your attention and for this invitation.
Thank you, Dr. Hachem, for that amazing presentation, and congratulations for your work that you do at Barcelona.
Thank you very much.
Prof, a couple of questions, Prof. Prof, this is a kind of a suspensory fixation, right? It is not very rigid like a screw. So have you encountered a scenario where there is a graft dislodgement? For example, suppose you're unable to clear the posterior soft tissues. There could be, it could be lax, isn't it?
So not as a suspensory, really suspensory, because a circular system. So the tapes come from posterior, from the first tunnel, exit point to the rotator interval, go through the cancellous surface of the graft, and again from the cortical surface, again for the second tunnel through the rotator interval, and goes back. So in the posterior side, when you put our guide, we split little the infraspinatus. The new guide, I didn't show it. We designed a new guide with the engineers from Artex. Has a tasty because you have 1 centimeter from the posterior glenoid rim. So in the same small incision, you put your hook and you split your infraspinatus. And when you take out this guide, the tapes are there. There's four tapes at the same tunnel. So when you pull to push the nut to the posterior wall of the glenoid, always be sure we are through this split of a little bit infraspinatus, and we are against the posterior wall. So we reach a strong fixation. And believe me, when you touch this graft, it's almost close to the stability of the screws. Not the same, but almost the same. We don't need stiff stability for the graft. There are many publications published about that 2 compression with the screws that could leave us a hypovascularization and could lead to much more resorption than remodeling. This is what I explained.
Thank you, Dr. Hachem. And some of your cases, you have shown that you have used an allograft, isn't it? Around 6 cases, it was an allograft, isn't it?
No, 15. I started using allograft because from my first series, after having done 21 cases, I only did 2 cases with autograft. I feel here the advantage in Barcelona, we have a good bank tissue. So they facilitate us a big allograft. But after following this patient with this technique, I feel the 2 cases have full resorption because the graft was bad. So we cannot control the quality of graft, but also we cannot control which patient could produce full resorption of the graft. We are looking now for the tobacco, for the drugs. In some patients with these drugs, as you call it here, marijuana, this type of patient in some cases provoke a full resorption of the proper iliac crest autograft. This is what we know. So I prefer now to use autograft. But if you have a good allograft, as I said in my presentation, you could be sure you will be a good result at the end.
Thank you, Dr. Hachem. And if I remember, there's a paper by Dr. Matt Provencher where he's used the distal tibia allograft, and the advantage, you have a cartilage surface. Do you think there could be an advantage with using a joint-based allograft?
It's a good question. This is what I discussed and asked for Matt. The problem, if we can use fresh allograft, is a good idea. I prefer it. The problem is the price, $7,000-8,000, only between $7,000 and $8,000 or euros. So if you put your fresh allograft against the neural head, is perfect. But the problem when you use DTA, but fresh frozen. So if you use fresh frozen, it doesn't matter. It will be suffer a resorption. It's not the same. If you speak about DTA, you should know DTA fresh, DTA fresh frozen. It's not the same, but it's a good. If you can use it, it's perfect.
Thank you, Dr. Hachem. We are also joined by Loy Al-Khatib, who's an orthopedic and sports medicine surgeon at King Sulaim Hospital in Dubai. Loy, your questions to Dr. Hachem.
Hi. Thanks, thanks, Abed, for the brilliant lecture. Thanks a lot. I think this is a promising technique, especially if you need a revision. It's also as a shorter learning curve. correct me if I'm wrong, and it gives a good results. I saw one of your studies published last year with a follow-up and led to a good outcome, to be honest. One of the questions that I need to ask you is about the compression. In order to get a good compression, you need a good graft. Is that right? So how do you make sure that your graft, let's say the bone block that you do is a good bone block? What features you make sure or secure you need to make sure this is the right graft to use? And how you secure a good compression?
So in the beginning, we have learned from the beginning. In the beginning, I broke one graft because I put almost 80 pounds. So 80 pounds, if you remember, when each pound is 4 Newton, 0.2. So yeah, so 8 pounds is too much.
Too much.
So in the beginning, I didn't worry about. I started to do it, and one time I broke it. So we went to the lab. We did a lot of tests. At the end, we found the final result. Only by hand, we can reach 110 or 125. But when you lose the nut, you again lose almost 30 or 40 Newton. So our now recommendation is to use only 25, 30 pounds and 2 times. We have a new protocol, and if you use a iliac crest bone graft, it doesn't matter because you have a cortical. So you should worry with when you're doing a lateral jet. For lateral jet, we use by hand to fix it because lateral jet have not a cortical. So at the end, we should, when you tension your graft, you should always see the bridge between the 2 tunnels to avoid any displacement. And in some time, if you have a displacement, I mean, if you broke the little bit this cortical, you stay there and you don't go much forward. So this is what important thing we've learned from the practice.
Yeah. And this is sure the graft will be extra articular, and you will fix the labral complex on top of that. One of the tricks that I have learned, I would be thankful to Dr. Kobiela in England that I learned that from him, is he's doing all the tunnels first, then shuttle the graft. So the tunnels, he drilled for the labral tear or the labrum complex to fix it. Then he drills for the shuttling the graft. So the tunnels will be there just to avoid any tunnels conflict.
So you mean for lateral jet, because Carlos used a lateral jet.
No, Carlos is using the bone block. Okay.
Yes.
Yeah. So he drills first. So once you drill from back to front, right, for the glenoid, and when you fix it, you need to drill again for the labrum, right?
Yeah, I understand.
So just to avoid to catch these sutures, you can drill first for all the tunnels you need. You can drill from back to front, and at the same time you drill for your labral. You prepare for a labral repair. This is one of the tricks that already.
I understand. Yeah, I spoke with Carlos about this one. I prefer to use fiber tack because the fiber tack 1.8, as I showed here, this is a key wire. So using key wire 1.8, if you go through the tapes, it doesn't matter because you introduce the fiber tack through the tape, and when you pull, is a tape against the tape. It's doesn't matter. This is what I'm not worried. I mark my tunnels, the level of my tunnel, but on the end, always it doesn't matter. I put 3 or 4 fiber tack at 5, 6 o'clock, and one in the middle and one in the upper part of the graft. So for me, if you put your anchor first or you put your hole first, maybe you can do it because you should use a big hole as Marcus. Marcus, I will do the same thing. He put 2.9 push lock, but I prefer 1.8 and using 2 and 3 or 4.
That's true. You can still use the 1.8 fiber tack, and yeah,
exactly. But still wire, not unthreaded drill.
What about regarding return to sport? When do you allow them to go back to sport using the bone cerclage?
Perfect. All my patients, I put only 2 weeks sleep think it's sleep, not for sleep, not for during the day, but to walk and to go out the house. And after that, we started immediately from the time zero with doing the stretching of deltoid muscle, scapular muscles. And if the patient do a contact collision athletes, I wait for 4 months. But if the patient do paddle, in Spain we have a lot of paddle, tennis, and I started at 2.5 months, almost 3 months. I started to keep him to go to the field to play alone, but with the contact sport at 4 months.
4 months, awesome. Okay, thanks a lot. Thanks a lot. That's brilliant. And see you soon in Dubai.
Thank you very much, Lloyd. Thank you. See you soon.
Thank you, Dr. Hachem, for that amazing presentation. That's all the questions that we have for the session. And I'm sure this is going to benefit a lot of people all over the world. Thank you, Lloyd, as well.
Thanks, sir.
Thank you. Thank you for having me. Thank you. Thank you, Lloyd.